once you start looking for it, you're going to find it over and over and over and over again. Like every single patient has some component of this. They're coming with a functional thing. Once in a blue moon, you run into somebody who doesn't. And you're like, huh. That's one you may want to write up. The other nice thing it gives you, automatic objective findings. If they've got decreased external rotation and decreased reveres, after you treat them, you can expect a 10 to 15 degree improvement in range of motion. Because again, that range of motion isn't hung up from a capsulitis or joint mouse, it's hung up because of function. So if you did the right functional correction, that should be back. And sometimes it is hard to tell. We've had a couple patients, I can't really tell which side's which, because sometimes you can get bilateral lower cross too.
That was me.
Yeah, but then we picked on one side because of what?
The weakness.
And lateral rape.
Yeah.
Yeah. So that the other component, if you can't quite figure it out, go for the tighter adductor or the tighter QL side as a dominant side for the lower cross. And then there's an area called the lateral rape or lateral raphe. Who's the anatomist here? I never say it wrong.
Lateral rape.
Yeah. The lateral rape, which is the transverse abdominis, external oblique, internal oblique, come into a common fascial tendon, a fascial sheath, right here. Then that sheath actually splits and surrounds the QL. So your core muscles are actually connected to your QL. What's the biggest muscle we love picking on as chiropractors now? QL. I'm always chasing the QL. Was chasing the QL for a long time, right? Hard to get to, deep, 3 layers deep. I mean, on, someone Sabrina's size, yeah, I can get to her QL. Someone of my size, good luck even getting to my bicep. It's hard to find. But there was an interesting study a couple years ago on, they were doing an ultrasound study, diagnostic ultrasound, and when they put pressure on the lateral raphe, the transverse abdominis contracted. Okay? So that means what? There's mechanoreceptors inside the lateral raphe. And that pressure on the lateral raphe causes transverse abdominis to contract. I'm like, well, what does that mean? Well, that means if the transverse abdominis is contracting, what's relaxing? QL. The QL. So that little pressure point on the lateral raphe is a great way to release the QL for someone that you can't get into the QL. If you can't figure out which side the lower cross is, lower cross tends to be the tougher one to figure out that's dominating on. Okay. Go after the side where the lateral raphe is tender. We'll look at that today too. Okay. So in all this mess, where's adjusting come in?
Joint dysfunction, because the muscles connect to each joint. Or like if you look at the spine and you look at the fascial connections, and you're like looking at the body as a whole chain, those muscles are connecting, and so you can trigger the mechanoreceptors and inhibit nociceptors as well at the joint level.
The spine joint?
Yeah, if it's connected to the spine, like it's to the mammillary or transverse or
You're
spinous.
close. You're getting close here. I'm going to refer to my friend Madison again, and her name is, it's just proprioception.
Oh my God.
If you read that Heidi Havoc's work, I don't know if you've seen her stuff, she's pretty good. I like her work she's doing. She gets a little bit A to C sometimes on me, which means that she observes something and comes up with a conclusion, and I'm not quite sure she explained B enough yet, though, to actually say this. So chiropractors are famous for this. We'd see something, observe it, and make up B. No. Doesn't mean they were wrong, it just means we didn't have science yet. But in Heidi Havoc talks a lot about central proprioception of the spine. And that's based on the small motories, the little tiny muscles that we had to dig through in anatomy, or the anatomage, whatever you guys were using. Those small muscles are really full of spindle fibers. They don't have a lot of muscle fibers in them. They're mostly spindle, which tells you what? They're actually sensory things. They're much more sensory than they are actually moving. I mean, what the hell is the rotator going to do when it's going from one vertebrae body to the other? It's not going to move that. It doesn't have the torque or the power to do it, the lever arm. So really, that's a sensory muscle. So what manipulation is probably doing, or adjustment is probably doing, resetting central proprioception. We're trying to reset proprioceptions outside in, but it's got to feed into an area that can take the proprioception. That's where the more and more evidence is coming in that spinal manipulation works that way. You know, we've been around so long, luckily, because it seems that spinal manipulation also has a downstream effect of getting better proprioception here. So now we're just attacking it both ways, peripherally with fascial work or ARPneuro, and then centrally with adjusting. The good news is once we've identified those patterns, we've actually figured out where to adjust. So this is when I was at some other schools with some older technique fellows, they get very, very nervous when they start talking this way, but we can determine site of adjustment by our fascial patterns, which actually makes much more sense than, you know. What has the worst inter-rater reliability in chiropractic? Palpation is terrible. The inter-rater reliability from doctor to doctor is almost non-existent. You know? And then when it says, well, if you did motion palpation, it's even better. That much. Inter-rater reliability of motion palpation? Not there. So.
I feel like a lot of chiropractors just fake it.
Well, I'll tell you this though, Joseph. There is some intuition
Yeah.
of what you're feeling.
Yeah.
You know, I'm sure Victor, Alec, we can all tell you intuitively over time you'll feel it. Like this just feels like it's got to go.
Yeah.
But when you really think about what it is, oh, that makes sense. So if we have this lower cross pattern, right, my conveyors on one side is limited. That tells me my adductor is tight, I'm in a lower cross. What else do I know is tight? QL. What's QL connect to?
The transverse abdominal?
The TO?
For spine, though.
Sorry.
TO junction,
In the spine.
TL junction, that's its upper insertion.
The root to where this transverse processes.
Okay, where's its lower insertion?
It's going to be in the superior iliac spine. Posterior ilium.
Posterior ilium
Like
with
the-
slips going into 4 and 5, right? Coming out 4 and 5. So where do I adjust on that side?
Lumbar.
Probably lower lumbar 4 and 5. That's where the QL, when we tend to get locked up, it's on the side where the QL is hypertonic. So now we can go attack L4, 5 as the adjustment on that side. Then, this was the old, the student asked me when I was at Logan, he goes, what's your typical adjusting pattern? And I think most of us would answer, who's been in practice for a while, it's the flying 7. It's lower lumbar, flip them over, mid lumbar, laying down, TL junction, that's 3. Anterior thoracic, that's 4. CT junction, that's 5. Cervical, 6, 7. So most of us adjust full spine. That's the progression we go through. And that was the famous flying 7 that most chiropractors still do. Not that it's wrong. Huh?
Still do.
Still do.
24 years.
Yep. When I practiced, I did that to almost every one of my patients. Almost without thinking, it's just a common pattern. So the lower lumbar is the 4-5. Then you just flip them over to the mid lumbar. I'm not sure I have a good logical reason for the mid lumbar, except I know as a patient, I hate getting adjusted on one side and not the other.
Yes.
Mm-hmm.
And almost everybody who tells you gets adjusted said, well, do the other side.
Mm-hmm.
So I do. I don't know if I have a good explanation of why.
It's comfort. Comfort for the patient.
Yeah,
And time-wise, it doesn't take long for us to actually perform that.
right.
You gotta make it even. And you gotta make them even, right?
You just don't feel
And most of the patients expect it.
So we
You know, as opposed to, we're gonna raise our hand and be like, I just need to adjust right there. You're gonna be good, it's all gonna reset. You're like, What the hell, it takes another minute.
I think they pay
Adjust
for
a
it.
full spine,
I
you
think
know,
they pay for it, so you're gonna do everything, right?
1000%.
So I can
Right.
make sense of the lower lumbars based on the QL. The mid lumbars, I could buy it a little bit from, I could make a story about the RAFE and the inequality of that pulling on the mid lumbars, but sometimes they go, sometimes they don't on the other side. And I'm not going to make a big deal about it because I'm more worried about the side that I know intuitively from a fascial side I want to get a release on, which is the lower lumbars. What's my next stop?
TL junction.
TL junction. Why?
That's the insertion.
QL.
Yeah.
The influence of the QL. What's the other thing that what's the other common area? What's the other common thing that we're starting to see here? QL is hyper. Glute or what? Hypo. QL and here is hyper.
Hyper.
How about lower trap? Hypo. So you're starting to see a commonality. Our common areas where we like to adjust is 4 or 5. TL junction's always in the mix, right? Common areas to find subluxations or fixations, whatever you want to call them,
All the junctions.
are the junctions. Those hypo-hyper junctions. Really common. CT junction, hypertonic upper trap, hypotonic lower trap. Really common area to find fixations. So how do I explain the mid-thoracic spine? Why do we always end up adjusting that? And how do we end up adjusting that?
What we usually do for extension restrictions, and it's because across they're hunched over a lot. So they get fixated like that. You feel the restriction, you want to pop them back out.
So what fixes, now I can make a story how the QL fixes the lower lumbar spine, right? There's slips that insert directly on it. TL junction, I can make a story about that because the slips of the QL go directly onto TL junction, transverse process in the lower ribs. How do I fix my spine anteriorly?
Supine drop.
Huh?
That's how you adjust it. Yeah.
Gotta get in there.
But what's fixing me anteriorly? What muscles send you at anteriorly?
So
As
it's
opposed to
Oh,
squares.
yeah, so as, well, major, but then you're gonna have,
I'm talking about mid-thoracic stuff.
Mid-thoracic.
intercostals and
I mean, intercostals are mostly sensory.
It's very anterior.
That's where it is.
wait, no.
I thought it was a
Oh, let's get this guy out.
Bones.
So what muscle can do that? I mean, what muscle can fix me this way?
Which way?
No, that's the pros.
Because remember, I'm adjusting this way, right? I'm trying to get it to come over my hand. It's an easy patient.
Be careful with Bonquisha.
it's just because the muscles in that area are hypotonic. And
Hypo?
And in the middle, and then above and below they're hyper. Or I'm sorry.
So what if where's the pec minor run from?
Yeah, I thought that was what's.
Yeah,
Pec minor runs here. So when it gets tight, it tends to pull the scapula up and over. But the scapula can only go so far. You're not going to ride it all the way over your shoulder. So what's the other thing it can pull on?
Sorry,
Right, the ribs go up. If my ribs go up, what's it do to my thoracic spine? Remember the bucket handle? It's going to fix it anteriorly. So actually it's the pec minor. So if they have an upper cross issue, you're going to tend up adjusting them A to P over your hand because it's going to want to go into extension because you're fixing them into flexion, right? So as the pec minor pulls up on my ribs, the ribs bucket handle and fix that the spine anteriorly. So even, like some of you guys might have experienced this too, if you normally adjusted A to P, you know, that way over their hand, and then someone comes and tries to adjust you P to A, you hate it. It's like, oh, it's not going to go that way. Stop doing that because it's already fixed anteriorly. But that has to do with the pec minor. So again, lift the ribs up. If it lifts the ribs up, it's going to fix this anteriorly. So that's where that's coming from. Does that make sense?
Yeah, so you're saying you do want an A to P, not for A? For thoracic?
Most of my thoracics are A to P for mid-thoracic spine, most. I'll still do some cross bilateral for the ribs, rib heads. But most stuff goes A to P. I found in practice most patients with upper cross have to go A to P.
It's a more comfortable adjustment as well.
Yeah.
A lot more finesse that you can roll somebody over, use their weight, as opposed to take a deep breath in, and if you're small, you have to really jump on them, you know, to get that a little more violent.
Rib breaker over here. Do you guys find that in practice more and more that you're doing A to P adjustments on thoracics with upper cross? Or no?
I've started to, yeah. I did.
I do both, depending on the patient.
Yeah. I mean, sometimes, like I said, I'll still do the, and we'll look at some of this today, sometimes I'll still do the cross bilateral stuff for the rib heads, but. So now we have, well, we got how many now? 4, right? We've got lumbar, TL junction, with thoracics. What's next?
CT junction.
CT junction. What are we going to pick on that one?
Transitional.
Transitional? And then we got the influence. What side do you think you're going to go on?
Right.
Where it's hemmed up.
Side of the upper cross.
Yeah.
Typically, that's what it's going to be. Okay, and it's going to either be C7, T1, or what's the other one that's here? First rib. So either typically we'll do a combination or first rib adjustment. And one of you guys showed me something Dr. Castellano showed you. Was that CT junction or first rib? That was.
CT junction.
Yeah, I like that. That was nice.
Name it.
What was it?
That right below the crown. That's what I call it, the
Can
Castellano
you
mode.
explain why,
Well, now I
when,
wanna know.
if it's on this side, why the first rib or CT would be affected on the opposite side? Like,
It's typically on the same side as the cross.
Uh-huh. But like with this, the case that I had, it was the opposite.
It's a good, here's what's really good about
Because I know
adjustment.
over time, it finally, when I went to, because I always had a hard time adjusting that side, and then finally, after the couple of treatments of what you told me to do, then it went. And she's been feeling better since then.
On the opposite side.
Yeah.
So here's a really good thing about adjusting. It doesn't do any, if you adjust an area that doesn't need to be adjusted, it doesn't hurt the patient. It doesn't do anything. And sometimes, like in your case, Jet, so if you tried a couple of times, it's not working, I would just go on the other side. Because sometimes the body forgets to read the book. We just don't know.
Well, her pain was the opposite side of the.
So sometimes just go flip over and just do the other side.
Okay.
So these are generalities. These aren't solid fast rules. You know, sometimes on the QL side, it's actually the other side that has to go, the lower lumbar. They're not hard fast. Because the good thing with adjusting is and that's when over time, Jasmine, you get this intuitive feels like,
Yes.
it just doesn't feel like it's got to go.
Yeah.
Let me try the other side. And
Okay.
sure enough, oh, there it is.
Right.
Now, it's not fitting your pattern, but that you don't care. It's just, okay, this is probably one off, but I know enough to check the other side.
Yeah.
We've all seen that, where we're predicting it's going to be this side, and it's like, no, shoot, it's the other side. That was a famous, remember Dr. Duart?
Mm-hmm.
He was famous for adjusting one side.
One side only.
Yeah.
I'm like, why?
And we had this patient in the Chicago clinic, and he had SI pain for years and years, and they kept adjusting and adjusting, and I'm like, well, why don't you flip him over and do the other side? This intern goes, well, this is where I'm palpating the subluxation. I'm like, do me a favor, flip him over and adjust the other side. Boy, was that guy pissed when he got up. He goes, 6 months. Is that flipping over? So, again, like I said, sometimes the body forgets to read the book. You know, and again, trust your hands. You know, trust that intuitive function and saying, boy, this just feels like it's got to go. So why am I talking so about adjusting when we got this ARPneuro thing? When do I do the adjusting? Before or after the ARPneuro?
After.
After. Reset the pattern and then get the central proprioception back. It's going to make your adjusting a hell of a lot easier to do than trying to fight something that's stuck into it. If I'm stuck like this and I'm trying to adjust you out of it, I'd rather get you here and try to adjust you out of it. It's going to be hell of a lot easier. All right. Next slide. Don't break this one.
Let's see.
Oh, go back one more. Sorry. The other thing, if you can't tell which side is, again, this lower cross is the one that's kind of goofy to tell sometimes. If you can't tell, go test the glute med. okay? Because the glute med will be inhibited on the side, typically of the dominant lower cross. Okay. So why is the glute med going to be inhibited?
Because
It's the adductor, right. It's the adductor that's probably hanging up your forbears, that's not letting you get into a full forbear position. It's probably the adductor that's hanging you up. So if you're not sure, test the glute med, because if that's inhibited, that's the side I'm going to dominate. Probably pick on the lower cross. And you'll probably find the lateral raphe tenderness on that side too. So it all starts to tie together. Upper cross a little bit easier to pick up. Lower cross sometimes tough. A little bit tougher to figure out which side's which. Like I said, you can have that straight pattern, like Madison, that left, or right. I
Yeah,
forgot.
but both my glute meds were also strong.
Yeah. Yeah, you were a tough case. You're a little hotball one on that one.
Yep.
And sometimes, I think you were saying sometimes the lower cross doesn't even come into play when it's just
I think
starting
that was
out.
our kind of a determination with you, Madison, too. We even kind of thought, I don't even think she has a
Yeah,
lower
even
cross.
with my
She
patient.
might not even be there.
Well, you said one of my adductors.
Oh,
So
that's
we worked
right.
on that, but it was fine after one treatment. It was mainly my left shoulder.
Yeah.
I mostly see a posterior pelvic tilt, especially with my athletes, because their hamstrings are overly tight and their adductors. And it's not, I mean, I've tested their glute meds and they're usually fine, but I'm usually finding that it's the hamstrings and the adductors that are like the biggest problems in their legs that's causing their pain.
Most of the athletes that I have seen and worked with, they have no glute muscles whatsoever. And it's really just like we've got to get their core activated because just like you said, we've got to treat all right here.
Right.
And that's the bottom line.
Would
Because
you-
movement originates here.
Yeah.
I go to blink and like this moves, you know, so.
Well, there's a bunch of assessments based on Shirley Sarmon, Shirley Sarmon is a PT, has a whole book of like watching belly buttons where they go. Unfortunately, most of America's like means belly button is out of position because of other factors. It's in the abdominal wall. You can tell which way stuff's going by the belly button movement, which you're right, Jimmy. Everything comes from that. All those black arrows point right here. It's right here. That's the center of where everything comes from. So if you're not correcting that, it's not going to work.
And
So-
that's why I think like this would be really phenomenal to look at more of like a biomechanical aspect on like an instrument and treadmill to see like how after a treatment you can change like your forces and not.
Here's what's fascinating. I just got a paper from this chucklehead on
What's
He just left. I can go get him if you want.
on it's similar to Debono. They're
He left too, out that way.
one of his sales rep was working with the lacrosse team.
USA Lacrosse.
USA
yeah.
Lacrosse.
USA
And they had
Lacrosse
force
Federation.
plates for vertical leap. So basically it was just a bilateral vertical leap from standing to hitting the nail, right? But there were force plates below, so they could tell you how much eccentric and concentric force is coming off of that. They must have had sensors on the muscle too. I could show you the study later today too. Though it was fascinating. So he had him jump 5 times, and then they put-
Ask the question first. 5 jumps, and then we put them on therapy and
Right.
5 more jumps.
Right.
What would be a good increase in like vertical leap, like after? Like how much do you think you could change in 5 minutes?
So they put him 5 minutes on the PRS on the adductors and DMO, or
Mhm.
just, yeah.
2 inches. 2 inches.
What's that?
2 inches. 10 centimeters.
4 inches.
Yeah,
They
4
were
inches.
flabbergasted. You know how big that is for anybody?
Is that a lot?
4 inches.
Take it easy, Gary. A 4-inch increase in vertical leap is dramatic on a 5-minute treatment. Now, what was fascinating was the force plate data that came back. So they have a side-to-side force plate. This person wasn't an athlete. He was a PTA who was a former collegiate athlete. So when you looked at concentric takeoff, it was all right-sided. A lot of right-sided. So they were right-sided dominant. even on a bilateral vertical leap, those force plates are extremely sensitive. They can pick up minor alterations. On a highly trained athlete, it'll fluctuate a little bit. It'll go side to side. You're never perfectly symmetrical. Soccer players would tend to be kick side dominant. So if you're a right-footed kicker, that's going to be your stronger side. That's dominating. So this person was right-sided dominant, and then the concentric contraction went up a bit, which makes sense because they're generating more force to get that leap. The really fascinating part was, after the 5 visits, the eccentric contraction side on the right side went up dramatically, which tells you what? What's the use of eccentric contractions?
It's to like load.
It's stabilization coming down, the landing part of it. So their landing eccentric contraction went up, it had to be like 50%. It was incredible how big difference was. And that correlated exactly with their force. Their landing force after on the 6th jump was dramatically lower than on the 5th jump because they had better eccentric loading landing on it. That going to prevent an injury? That. So this guy's jumping higher and landing softer just because of a simple reset.
In 5 minutes. That's all it took.
So we literally just got that paper on, it's not a paper, it's a report. We literally just got that Friday. So there's a lot more work to do. I don't know if it's a one-off. We didn't have a control, but boy, that's pretty promising.
Yeah. We walked in and he got invited there to show because they can't believe it. And they were like, okay, you think you know what that does? Let's put somebody up there, hook them up, and the whole 9 yards. And they were like, really? Wow. So we didn't even know that was going to happen.
You should have. Anyway. A couple more quick things, and then we'll take a little longer break so you guys can get a snack, and then we'll set up the lab, too. Does that sound good?
Yep.
Or do you need a break now? You okay? Good. Okay. So where do these magic pads go? So, why we were so excited about trying these protocols is Jake and I worked a lot with this. We just spent a weekend here putting pads all over each other and saying, well, does this work? Does this work?
Fun times.
Huh?
Fun times.
Fun times. We kind of stumbled on this one. So I put some pads by the hypertonic muscles. So the pec, tail of the pec, and then the black pad on the opposite adductor. So we're actually crossing. So we're doing that cross pattern again. And then the same thing on the other side, a black pad on the adductor and a red pad up on the opposite pec. And then turn it up.
Are you going to the belly or the insertion?
The tail of the pec, we're trying to catch a little bit of the pec minor and the tail of the pec. I don't want to get too close to the heart, obviously. So a little bit more lateral. And even what we've been finding fascially, like I know particularly like with Abby, we found her fascial restriction was out where the pec bicep meets. That's where a lot of this lies. So you still want to try to catch some of the pec minor. We use the longer pads. We're actually going to try the smaller pads. The problem is this causes contraction. So when it does this, those pads bunch up and you kind of lose conductivity. So we'll try a smaller pad. And then the adductors, those are always interesting.
So the pads in our clinic we can use with these?
We have more pads.
Okay.
No, the pads in the clinic aren't strong enough. I mean,
Okay.
these conduct a lot better. They have silver wire in them.
Yeah.
Yeah.
There's only one set of pads that actually work, that are FDA approved, that can take this kind of power.
Okay.
AED pads, yeah.
So basically, we put this pattern on, and I'm going to put you through an anterior sling exercise while this is getting zapped, and keep turning up the power. So we'll bring you up, and most patients freak out a little bit when they start contracting. But we try to get you to fight through that, and as you accommodate. A typical session's 20 minutes?
20 minutes.
About 20 minutes to run you through. So for an active care, 20 minutes is pretty good.
And it's 20 minutes on the clock, from kind of start to finish, but it's a couple minutes of warm-up, active care, couple minutes of cool down. You can shorten those ends in practice when need be.
Should-
Well, the
does that-
good news with this thing is, and you know, when I first went to saw Brian's office and his partner Sam is treating hundreds of patients a week. It's amazing, mostly with this protocol, but they're doing it all because they're stubborn. You know, I said you could train someone to do this and not have to stand in the room and do this, and they don't have to be a license, you know, in most states. So I can train you how to put these pads on, or I could do the initial placement, the initial treatment, and it's on you guys. So this is, to me, a really good practice serve because I don't have to stand there and do it as a doctor. I just have to figure out where it is.
Would a half an hour appointment be enough? Because like in our clinic, we get 30 minutes for our follow-up visits and an hour for an exam.
That's exactly what we do in practice.
So 30 minutes would be sufficient?
Yep.
Cool.
You know, because you already know where you're going to adjust them.
Right.
So it shouldn't take you a lot of time to figure that out. And if you take it more than 10 minutes to do a full spine, take it more than 5 minutes to do a full spine, you get it so slow.
We'll be obviously probably not doing this in the treatment room. We wouldn't be doing this in the treatment room. We would probably take him to the gym or
This,
the overflow.
so I'm going to speak with probably Dr. Castellano on this and Dr. Brown and Harrington and see what, to me this is the overflow treatment room. I'm going to try to put a TRX down there. TRX is really good when we see the sling exercise, how to use that too. Because it's more of an active therapy.
Right.
And then there's adjusting tables right there, and you can adjust them.
I wish we could take our like second floor gym down to there.
Yeah,
Like some of the equipment because it would be nice.
yeah,
Yeah.
it would be.
Well, program director.
Coordinator.
Coordinator.
I don't know what I am. They keep changing it.
Yeah.
I'm a Keiser.
I can show up. I don't care. What do I care? 62. Who gives a shit what they call me? Anyway, sorry.
That's why they hire ourselves.
Yeah.
Like for your black leads on the kids, your red leads on
ARPneuro.
contrast, for instance.
No.
You guys haven't tried opposite sides of the body or anything?
It is opposite side of the body. It's black. It's black red.
Right, I understand. I'm talking about like black here, red up here.
Now the fibromyalgia lady does posterior neck with red and black down low. So I'll see what she says, what her theory is behind that.
What's the difference in the pads?
The black finds
Black
red.
finds red.
Okay.
So
It's a one-way street.
right there, he was kind of going across the ground up there. More sensory comes from ground up. So, good question.
Yeah, this is for, maybe like, how do you build this, Cash?
No.
No?
Mm-mm. So most of the active care, obviously everything's moved to active care. So you're obviously doing an adjustment.
Yep.
You're doing neuroed,
Yep.
therapeutic activities, therapeutic procedures, and electric stim.
Okay.
So we're billing 5 things in total,
Yep.
depending on, you know, they have a 3-visit, 3-service max or something like that, then you pick the 3 ones they're going to pay the most on,
Correct.
right, and bill them. Typically, I have a new hire, in my office as well, so, kind of trying to get her up to speed to understand that
You finally listened and hired someone.
we probably do 7 billable things to every single patient that comes in, but we can only bill a certain amount. So we just have to be astute enough to bill the ones that they're going to pay the most on, even though we're doing a service to the patient even more than what we get reimbursed for.
Yeah, and the average in Chicago is pretty good for a visit. In Florida, I don't know. But
What is it down here? Who's in current practice? What do you guys get down here? Do we know?
Well, because, for example, in Massachusetts, Blue Cross pays the best, and they pay for 2 modalities only. So
Okay.
obviously,
Plus an adjustment, or?
plus adjustment, yes.
Okay.
Modalities means like the 9712, 9710.
Yeah.
But in Florida, Blue Cross Blue Shield is part of Cigna, which pays like nothing. So like a lot of them could only give like 1 modality, so we're 2, not maybe, but it was like $16. Like it's really sad.
Yeah.
Yeah, like in Mass, you can maybe a visit, everything else, you can probably like average to like $100 per patient if they have obviously good standard insurance, but here just a little above. So that's why, like, how do you justify like buying a $12,000 machine, but you can only get
Well,
like.
it's different. Some of the guys set it up like they do with shockwave therapy.
Okay.
Like shockwave has a very specific protocol. There's 6 visits over 6 weeks, and what they do is they just they bill you up front. Like I know one person in Illinois, no, Missouri charging $3,000 for a shockwave session for the entire protocol,
Okay.
and they just take it up front. I've heard of people doing.
We did the same, yeah,
There's an
before.
ARPwave model where they do that too, saying we're going to run you through this protocol. Here's your for $1,500 or $2,000, whatever the fee is.
Right.
So you could run it on the cash side that way too.
Has, okay.
Yeah, we advise between 100 to 150 a visit cash wise,
Yep.
because it does take a bit more time, not in this kind of approach, so to speak, but you know, whatever geographically you think you can hang with. Some doctors are charging 70 or 75 or 80, you know, and we do have some people in like California are charging 250.
Yeah.
You know, it's, can your market bear that? Can they pay that? But what I can tell you is when you start fixing things and put pads completely away for somebody that has the chronic pain, that you get them better in one treatment, and it's not going to last, but you're going to get them better. The light bulb goes off that I've been dealing with this for 10 years, and you just treated here and here, and this goes away. They know they can only get this treatment if they come back here. They'll find a way. You know, if you're astute enough to show them this and explain it correctly, you'd be really shocked to see the people that you don't think have that kind of money to do it or have the means, and they do. Because they know it's the only way to get better.
I mean, a good example is, you mind if I use you, Jasmine? Like Jasmine just came in earlier and said, I've got labral tears. Well, she's a chiropractor, not a chiropractor. You think that's not in the back of her head? Like, oh, shoot, am I going to need surgery down the line to
My shoulder
continue
was
my
so
job?
strong.
Of course.
Now, you change this with this, so they start feeling a lot better, a lot stronger. Then, if she's a patient, you know, is she going to pay for that? Yeah. I'm going to do this instead of surgery? Heck yeah.
Right. It's like, how many people in this room have some sort of pain currently right now? Why? You're in school. You could use this clinic, be treated 5 times a day if you want. Right? Just think about that for a second, right? A patient, it's like being a dentist and having bad teeth. Why? Right? You have all the instruments and all the tools. How come you're still in pain?
That I keep asking myself that.
We have a bit of an answer for that.
Because it's got to go to the office of the chancellor before we can use it.
Well, what was profound when we were doing this, because the students who know me too, I've had trouble with this stupid ankle forever, and it's getting better and worse. And I tell you that we kind of stumbled onto this thing, and they did the anterior swing protocol, and all of a sudden I'm like, I could do a toe up, I could do a toe raise. Holy crap! Just went away. Now it comes back and forth because, like an idiot, it felt better. I'm like, well, I should join Orange Theory.
No.
Let's go to excess.
I made you feel that good last semester?
Huh? Yeah. Actually, Jeremy helped a lot. He identified some short leg piece too. So from the hip surgeries, it's not exactly even. Anyway, so I did. I went back to Orange Theory, and I could still do. Now it still limps around once in a while. You can tell the day I went to Orange Theory because I'm usually limping. But it goes right away, and just a quick session, and it's back to normal. I could live with that. I'm good. You know. Probably if I did it consistently, to your point, I treat everyone but myself. If I did it more consistently, it would probably stick a lot longer. I just have to get on it and do it. So, and then working with Jake. Sorry,
With my hip, yeah. I mean, so I've been working with this probably 7 months when it came to, I've had hip issues for at least the last year. And I tried with the physical therapy, I tried hers. That was a game changer. And then when we started going through this with the middle cross, I've been running. And that's been in the course of the last, for 2 years I haven't run. I used to run miles. And I've been consistently running a couple miles for the last couple weeks. So, and it was kind of like you. When I did it, I would limp the next day. I have not been limping since then. I can tell that it's a little stiffer, if I run the day before or whatever, but it's definitely getting better, and I'm able to go a little bit further each time. So there's repairing happening, and if I was more consistent with this, it probably would have been faster. But I would gauge I probably did a little bit more sessions than you did with this.
Are you saying the running caused the stiffness, or like getting?
It could have been a whole host of things. You know, I've done a lot of weighted rucks, and I think it's just the course of my life.
Okay.
It probably, something probably inflamed it, but the treatments have actually allowed me to go back to running, which
Okay.
I've taken 2 years off.
Awesome.
So I'm excited
Looking
about
at
it
Jake,
now
the way,
because it's just been
the way
recent.
his pattern is, if you don't mind me talking about that.
No, no, no.
There's probably a little bit of FAI too
Uh-huh.
that's causing
Yeah.
that decreased range, femoral acetabular impingement.
Mhm.
So,
Yeah,
which
that's
is
right.
not uncommon, and that's, hence the reason I have 2 metal hips was undiagnosed FAI for years and 14 years of football. Well, those 2 usually equal total hip later in life. But I think with Jake again, that's another example of what shoot I've got FAI, I'm destined for surgery. But maybe not. Maybe not. Maybe we get enough function, enough movement. Will he ever get full range on Faber's? I doubt it. But it's a lot better than what it was, and it went from a hard end field to a soft end field. So we're at the limit of his capsule. Now, it's going to decrease from the other side, but don't chase normal either. Because if someone could define normal, let me know. Chase good enough. Or chase, this is good for you. Because someone with FAI, they're never going to get their full external rotation of their hip. It's physically not possible. So, get to good enough. If you could change that from a hard end field to a soft end field, at least that's one thing we talk about when you're feeling this stuff. Describe your end feel. You want that soft end feel, that spongy where you can go a little further. Hard means you're out of position. It's the bone stopping the bone. So this is the hypertonic one, and this is the most common one we'll do. Okay, this has the most effect. The hypotonic one is the exact opposite. We're going to go into the serratus anterior and onto the glute medius. Okay, this one has a good effect, but not as dramatic as effect as the hypertonic.
Correct.
So we tried both, and when you did the hypertonic, it's like, man, you felt that right away, like straighten your whole system out. So this one, you felt it too, but to a lesser extent. So why do it? I think if I was treating a patient on a regular basis, like a 3-time-a-week patient, I would do hyper, hypo, hyper. So, because you don't want to keep doing the hyper over and over because you're going to get a combination. So mixing it up a little bit, that hyper, hypo, hyper protocol, probably run that for like 2 straight weeks. And you'd probably reset the pattern by then. That makes sense.
Is this a daily protocol, or you guys have protocols?
I would say 3 days a week for
I
practicality.
treat most of the athletes every day if they're trying to get back on the field.
Yeah.
Yeah.
If it's an everyday protocol, you go hyper, hypo, hyper, hypo, hyper, with hyper predominating. You always want to do more hyper than hypo.
That's what I did the first week with this. I just combination of it.
Yeah. And it keeps you from accommodating right away to the same pattern over and over again. Next.
I'm sorry, I'm kind of confused. This is for sympathetic, right? So you're hitting hyper with hyper?
What's that?
Like you're hitting with sympathetic, you're exciting. So you're hitting the hypertonic side with more sympathetic innervation. So wouldn't it be?
There's a question we always get. Why am I stimulating a hypertonic muscle?
Right.
Right. That's a common question. Just get that all the time. Remember, when I add stimulus to an area, the muscle's going to try to return to normal resting leg. The muscle's going to try to normalize.
Oh, that's right.
Right.
So they're trying to break that like pain spasm cycle.
Right.
That's causing
So,
that
like the pec typically when it gets into the pain cycle, it shortens. The rhomboid lengthens. So, whatever that, again, I still think the rhomboid is probably lengthening because this is the one that's reacting to pain. But that shortening is going to try to lengthen, go back to normal resting length. So you'll see.
Sounds like fatigue.
It's like AFib, if you put 2 paddles on somebody, right? You're still shocking something that's going into spasm.
Yeah, the neurological sensation is not so much fatigue, it's just whatever aberrant neurological, whether it's in a gamma loop, said it again, or
You
not.
forgot the alpha part.
It's going to try to break that aberrant neurological cycle and go back to normal resting rate. Remember, that shortens neurological. It's not functional. It's a neural response. So we're trying to break that neural response and go back to normal rate. So it's a good question. We're constantly asked that. Why would I dump more stimulus into something that's overstimulated? It's not overstimulated. It's aberrant. It's an aberrant signal.